Okay, good afternoon again. Thank you all for coming. Thanks to those who are on Zoom. I know that for the folks not affiliated with the med school, this is pre-quarter activities, which is a lot to ask, but I'm excited to kick off this year. For those of you who do not know me, I'm Dr. Whitney Purtle. I'm a new faculty in community health sciences and affiliated with sociology. And I'm so excited to have the Moments sociologist right now, the current president of the American Sociological Association, talk about her but to do a full introduction, I'm gonna throw it to my colleague, Matt, who inspired this whole idea.
Hi, everyone. I'm Max. I am a primary care doctor here at UCLA. I'm an assistant professor in general medicine and health services research. How did we get here? So I was a third-year medical student on my OB/GYN rotation and really struggling with fitting as a Black man in a space where most people at work are white women and like maybe a sprinkle of women of color. And as a med student, I had this habit of like going to the sociology literature to try to understand, to try to make sense of what experiences I was having. And that's how I stumbled upon Dr. Harvey Wingfield's work at this point. I don't know, 7 years ago, it's been a while. Um, and it made me feel like, okay, I'm not crazy. These both racialized and gendered experiences I'm having are real and have been studied empirically in other spaces. At the time, I think your work was in the experience of men of color in nursing. And it turned out I actually wanted to go into OBGYN. And like I kept thinking back about her work and wondering, like, am I going to be okay in this field? Long story short, I did not go into OB, but for multiple reasons, not only because I felt out of place or felt occasionally unwelcome, but most recently I read her latest book, Gray Areas, which is, I would say, a sort of more lay version of a lot of her work, a lot of her academic work, and I loved it. And I reached out. I was like, "Oh my God, hi! I love gray. I love gray areas." And I had met Dr. Harvey Wingfield once at ESSS, Eastern Sociological Society conference in Philadelphia, right after that third year of med school, and I was like, "Oh my God, you're like my Beyonce of sociology." Because your work has been so illuminating and helping me make sense of my experiences. So I am so thrilled to have her here in person to share her work as it relates to the experience of Black healthcare workers in this new economy. Dr. Harvey Wingfield is the vice provost at WashU St. Louis and has done amazing work. I would argue that she's the foremost scholar when you think about labor, gender, and race. And yeah, it's really an honor to have you here and to introduce you. And I look forward to hearing about your work in real life and beyond the pages of books.
Appreciate it. Thanks. Thank you so much for that kind introduction. And thank you also, Whitney, for your help in putting everything together and for your kind words as well. So the research that I'll talk about today pulls primarily from Flatlining, which is the book Max mentioned. It is my second to most recent book, but I'm going to weave in some things from Gray Areas here as well. But Flatlining seems the most relevant for this particular audience, given its focus on the healthcare industry. And so what I'll talk about here is pulled from that data, but it takes a different approach than what you'll actually read in the book. So this is not just recapping things in the book because I want people actually to read the book. So I don't want to give away too many spoilers. But the title here today is Professional Work in a Post-Racial Era, Black Healthcare Workers in the New Economy. And so okay, hold on. Okay, got it. To get a sense of how we can think about Black healthcare workers in the new economy, I think it's useful to start off thinking about what work used to be and what work used to look like, and to think about that as an interesting comparison to what we have today. So when we think about what work used to look like, often we go back to what I think of as this idealized post-World War II work era. And this is a picture that we have of what work looked like during this time period, where work was pretty available to anybody who wanted it. Workers largely had a fair amount of job security. You could count on going to one job and staying at that job for the duration of your career. There wasn't a whole lot of turnover or transition. People were able to experience pretty competitive benefits in the area of having access to healthcare, retirement benefits, and so forth. There was a fairly robust middle management sector, so people could come into one organization and fairly expect that they could work their way up through that organization over a period of time and then retire with some sense of security. Of course, it's also important to point out that when we look at this post-World War II work world, this is also an era that was characterized and defined by pretty significant occupational segregation. So this picture that I'm painting of what work used to look like was very much a picture of what work looked like primarily for white men. This is not necessarily what the picture looked like for people of color or for white women. And it's also a picture of what work used to look like that was very sharply defined by the presence of a fairly robust public sector in the sense that there was a thriving public sector in many industries, and that people could rely on that public sector both for training, for credentialing, and also for employment. So if we fast forward today to what work looks like now, we're looking at a pretty comprehensively different picture. That image that I painted of this post-World War II work world is largely obsolete at this point in time today. We know that today we're looking at a work world where there is declining unionization and that workers have far less job security than they used to in previous eras. One way to approach this might be to make an argument that workers now have more autonomy and more self-direction. They can choose to change jobs and make different decisions about which courses of employment they want to stay in and which other areas that they want to pursue. But ultimately, these shifts in work have left them with different options and fewer options in terms of job security, and switching jobs doesn't necessarily create that. Organizations are also flatter than they used to be in previous eras. We see less of that opportunity to move up by staying in one organization because companies tend to be more structured around flat organizations where people do different types of work without necessarily having those same opportunities for mobility. Workers also take on significantly increased responsibility for benefits, particularly when it comes to health and retirement benefits. When I talk to my students about this and raise the idea that there actually once upon a time used to be a thing called pensions, they don't even understand what that means because that's so alien to the idea of how we think about work and retirement today. Also, at least until very recently, organizations also offered more stated support for diversity. Up until around this year, it was pretty common for companies to explicitly state that they were committed to diversity, that that was a core part of their programming, and that it was something that they valued. But ultimately, when we look at what work looks like today compared to what work used to look like in this previous era, we see a largely frayed contract between organizations and employees. And what used to be this mutually generative understanding that people could put in their time to an organization, the organization would take care of them, and that they could count on the organization for some support, again, provided they were people who fit certain demographic criteria, isn't really the case anymore. There's a lot more economic and a lot more emotional uncertainty that comes with the ways that work has changed for workers and on the part of organizations. So sociologists and some economists will refer to this as the presence of the new economy, this idea that work has become a lot more shaky, a lot more uncertain, that there's less of a focus on collective work, collective bargaining, certainly. And in this new economy, professional work has for a pretty fair amount of time existed as one of few routes to economic security. It becomes one of the kind of last areas standing, that if you do have access to a professional job, then this can be one of the ways in which you can feel somewhat certain, maybe not definitively so, but somewhat certain that you're going to experience some economic security. And professional work has benefited very heavily from technological advances, from the growth of the knowledge economy, and again, until recently, was very much a place where the focus of diversity dialogue was largely centered. And even now, with all the changes that we're seeing around diversity and inclusion and how people talk about it, that focus has still been on what diversity means or what not having diversity means for many professional occupations. What does it mean to take away diversity in the legal system, in venture capital, in the tech industry, and things like that? So what I wanted to focus on with flatlining was to try to understand what this new economy means for Black professionals. How are they navigating this different economy that has changed so much from the more solid one of previous eras, even if they weren't included in that one? So there are some existing theories that give us some insights into what we might expect to find. Sociologists like George Wilson, Matt Huffman, Vinnie Rossino have argued that we see a lot of downward mobility as the public sector has increasingly privatized. And a big reason for this is that the public sector had for a long time been a source of employment and economic security for many Black workers. They could rely on federal work and on public sector work because the expectations for anti-discrimination law and rules were higher. And so public sector work often became a place where Black workers saw this process towards middle class stability and economic advancement. But as the public sector has increasingly privatized, these sociologists argue that we are seeing much more downward mobility as those opportunities for public sector work are slipping away. Existing researchers like Sharon Collins, Frank Dobbins, Sandra Califf have also pointed to diversity failures at organizational and policy levels. And obviously I wrote this book well prior to some of the events that are happening now, but I don't think we can make a credible case that we are seeing diversity really strengthening and solidifying in the past year or so. Even before the events of current administration and the cultural shift around diversity, researchers were still making pretty strong arguments that many organizations were putting into place policies that were not necessarily effective or most effective when it came to actually diversifying the organizations and the industries where they were housed. And finally, my colleague Jake Rosenfeld at WashU has made the argument that declining unionization has served to exacerbate racial wage inequality. As we have seen union membership decline over periods of time, part of what he's found with his research alone and with sociologist Bruce Western has been that a consequence of this declining unionization has been that racial wage inequality has grown wider and more solidified in the absence of union membership and collective bargaining that can try to make sure that these wages are driven higher. So this research gives us some insights into what we might expect to find facing Black professional workers in the new economy. We might expect to find that they are experiencing downward mobility as the public sector is shrinking, that they are in these spaces where there's a commitment to diversity that's not actually being realized, and that they're experiencing racial wage inequality as a result of declining unionization. But I think that there are still some unanswered questions about how Black professionals themselves are dealing with and responding to these examples of work transformation. For example, does the privatization of the public sector mean that Black workers are less likely to want to go into that type of work as it continues to privatize and continues to shrink? Do existing failures around diversity have an impact on Black professional workers who may have to navigate workplaces that are changing their focus on and their orientation towards diversity? Does declining unionization leave Black workers less convinced of and less in favor of unions as a mechanism for changing racial inequities in workplaces? We don't really know the answers to these questions from this work. And so these were things that I wanted to delve into with flatlining and to try to understand better. And so this takes me to the core questions that drive the overall study. When it comes to flatlining, the key questions that I wanted to ask were what the new economy means for Black workers doing professional work. As many industries in the new economy become more privatized, more stratified and unequal, where and how do Black professionals fall? What are their challenges? What are the opportunities they have? Who are the winners and losers as we navigate this new economy that's become more uncertain, with the exception of professional work, which remains kind of this last route standing to more economic stability? So as I was thinking through the project, it struck me that the healthcare industry was actually a perfect case study site for trying to understand these questions better. And the reason I say that is that all of these larger macro level changes that are happening in work and how we understand what work looks like and how it's shifting, all of these things are playing out in the healthcare industry in very precise and specific ways. For example, when we talk about the increasing privatization of public services, healthcare is a perfect example of how we see that what I think of as a tiered system of care. A private system where there is where there are opportunities for well-off, healthy, quote, responsible patients who are able to access private facilities, use private insurance, and get the best care that they are able to afford. And then there is a public system of care, which is the minimally funded public sector care that is available to everyone who isn't able to access their previous era, right? And this is a direct relation of the shrinking of the resources that go towards private sector services on all fronts. I think that this emerging tiered system has also emerged with, this increasingly tiered system has also emerged in tandem with changes in US racial demographics. So as we are seeing this increasingly tiered system of healthcare, where this private system is available to a few, this public system of care is available to the many who often have to use that public system of care are often people of color. As we are seeing US racial demographics change, private healthcare is becoming increasingly commodified and something that increasingly becomes the province of the very few who can afford it. And at the same time that healthcare has changed in this way, it has happened as routes to professional work have become less stable. So we have this increasingly privatized commodity where the public underfunded care is available to a growing number of people at the same time that the routes towards doing this type of professional work have become less stable, less secure, less underwritten by certain forms of support in this new economy. And so what it paints a picture of is healthcare as an example of the ways in which work and the economy are shifting to become more commodified, to become more fragile and more uncertain. And the pathways towards doing work in these types of fields have become increasingly less certain as well. So just for some demographic data, I think it's useful to point out where we see Black professionals falling in the healthcare industry. It probably will not surprise anyone here that when it comes to physician work, Black workers are least represented at 5% of that population. We see a bit of increasing representation among paramedics, physician assistants, and certain forms of technicians. Black workers are 10% of registered nurses. We see their presence start to increase the higher we go into certain forms of technical work. For example, health practitioner support techs, medical and clinical lab techs, medical records and health info techs, and licensed practical nurses have the highest representation of the ones covered here at 23%. So what we end up seeing here is a picture where Black workers are least represented among the physician population, arguably of these categories, the most prestigious, most specialized, and most technical, and most represented among certain technical fields, which are at the different end of the occupational spectrum. So with this backdrop, what I want to focus on today are a segment of some of the questions that I address in Flatlining. I start with this overall question of how work transformation in the new economy has affected Black professionals. But what I focus on specifically are the ways that diversity ideology has become implemented in certain occupations, particularly in medicine and nursing, where diversity ideology had become fairly unremarkable and fairly mainstream. The question I ask in the presentation, and that I'll address in this presentation, is around the impact that this has on Black professionals. When we think about aspects of ways that work transformation has occurred, this focus on diversity ideology and moving towards a more centralized and normative understanding of diversity as something meaningful and significant and important, even if contested, had become pretty standard in medicine and nursing. And so what I try to do with this presentation is to pull out some data from the book to think about and to try to understand better what that means for Black professionals to work in these fields that are more tenuous, more uncertain, more rocky than they have been in the past, but now we're also centralizing these ideas of diversity and inclusion as things that are at least worthy of conversation and understanding. So in order to address this, I engaged in intensive semi-structured interviews with 75 healthcare workers who spanned a variety of fields and subspecialties in healthcare. I spoke with doctors, nurses, physician assistants, and technicians. Interviews generally ran between 1 to 2 hours, sometimes a little longer or shorter depending on the respondent in question. I also pulled data from the American Panel Survey, which is a survey that WashU administers on a quarterly basis to a representative sample of 2,000 US adults. And then finally, I did field observations in 3 settings. So I spent time with a Black man working in a public sector facility in emergency medicine, a Black woman working as an OBGYN in a research hospital, and another Black woman pediatrician working in private practice. And the idea there was to get an on-the-ground sense of what respondents were telling me and to try to see ways in which I could triangulate the data that I was getting from interviews with the firsthand understanding of what their experiences looked like in this work setting. So the overall picture of my findings, and this may seem counterintuitive, but what I found was that diversity initiatives in many cases largely left Black professionals feeling apathetic, indifferent, in some cases even annoyed. And in generally, I did not find a lot of support for these initiatives as they were put forth in these facilities. And this wasn't because respondents didn't believe in diversity. It wasn't that they felt that it was unimportant or that it didn't matter or that it had outlived its usefulness. Instead, what I found was that for many respondents, diversity efforts were really not very reflective of their racial work experiences. And when I delved into what those experiences were more fully, I found that they varied pretty significantly by occupational status, and even within occupational category, they varied pretty significantly by gender. But ultimately, that left these respondents with a sense of distance from the types of initiatives that are part of the transformation of the new economy, and not as much support as we might assume. So in breaking this down further, I want to start with Black doctors. And when I talked with many Black doctors in my survey about what types of diversity and inclusion mechanisms and programming were present in their workplaces, they usually described being subject to cultural competence training. Again, I think this is probably familiar to this audience. And most respondents would say that they had to go through this type of training over a certain period of time or at a certain interval as part of their work, and that it was required. but they largely viewed these as unnecessary bureaucratic hurdles. They were not in favor of these types of cultural competence trainings as being a core part of the diversity initiatives that their workplaces put into place. And largely this was because these types of cultural competence trainings seemed very disconnected from the ways that these healthcare workers saw race affecting their work. And so when I asked a little bit more to try to understand how they did see race affecting their work, or if they did, what they told me was that they were not in a position where they largely experienced overt everyday racial aggressions. It wasn't a thing of coming to work every day and dealing with overt macroaggressions or explicit hostility or anything like that. Instead, they were more likely to say that race affected them through what we might think of as structural or cultural processes, and that those were the primary ways in which they felt that their workplaces and work experiences were shaped by race in ways that diversity initiatives did not address. I also learned that with race embedded in these structural avenues, gender actually became a more obvious form of overt bias, particularly for Black women physicians. So I'll talk about this a bit more. Here's a quote from Randy, an emergency medicine doctor that I spoke with. And when I talked with him about what types of diversity initiatives were present and what he thought about diversity initiatives at work in general, he actually rolled his eyes and told me it's the right idea, but that stuff doesn't mean anything. Nobody takes it seriously. Obviously, I think more diversity is important. It's necessary. But the way they do it, the trainings and modules, it's just one more box to check. They just want quick fixes. Doing the hard work, really changing the profession to get more Black and brown people in here, that's not sexy. So I include this quote from Randy because it's pretty emblematic of what I heard from a lot of Black doctors. This idea that more diversity in medicine was valuable, was necessary, was important, that was pretty consistent. But the idea that manifesting that via cultural competence trainings, one more box to check, one more bureaucratic thing that had to get done, that actually wasn't so valuable to many of these doctors because they saw the issues that diversity needed to address in medicine as being ones around low numbers of representation. And we'll see more about why that was the case in next slides. This is a quote from Allison, who is a geneticist. And when I asked Allison to tell me whether she felt that race had impacted her work, she told me that it did. When I asked her to give me some details, she said, "It's impacted my work just because my interests are focused more so on health disparities, medically underserved populations, minorities, those who often do not know about genetic resources or genetic services that are available. And I find it difficult to identify mentors or people who are familiar with those populations, people who are also passionate about educating those populations about genetic services or resources. So I have not really had much luck identifying people who are working with those populations who can help me better address some of the needs or some of the disparities that I see." So I pulled out this quote from Allison for a few reasons. One, I think it's really significant that as a geneticist, she's in a field where Black women are very significantly underrepresented. But when I talked with her, again, about the dynamic that that had on her work, it wasn't a dynamic of coming to work every day and feeling mistreated by colleagues or mistreated by patients or anything like that. Instead, she points to what we might consider a more structural dynamic, this aspect of not having access to people who are mentors, who can give guidance about the particular focus that she wants to take on identifying underserved populations and pointing out genetic treatment that can impact those particular groups. And when we think about how the new economy operates with its focus on relationships, on networks and connections, this absence of mentorship and this lack of the types of relationships that can actually guide advancement takes on even more resonance and significance. Because what Allison is describing is being in a position where, again, those overt aspects of racial inequality are not really a core fundamental part of her work life, but what is missing are the networks, the connections, the relationships that drive advancement in the new economy and still leave Black workers underrepresented. Now, with that said, I don't want to give the impression that when I spoke with Black doctors, they never related any of these types of interpersonal dynamics around race or inequality, because that was not the case. The way that they did characterize these, though, was what I refer to in the book as the that one time experience, where they would say something like, well, there was that one time when this person said a thing and I didn't like it and it was weird and I didn't know how to respond to it, but that hasn't been the totality of my experience because I have been focused more on these structural or cultural aspects. And so I'll give this quote here from Edgar, an internal medicine doctor, who actually was the person that sparked that one time comment for me. And he told me, "So I can think of one time when I was working in the ER, and God bless him, there was a fellow who came in who was piss drunk, having chest pains, had no insurance. I'm the only one manning the ER. He comes in and decides he wasn't going to let no N-word doctor take care of him, so he fixed me by getting up and walking out. That was beyond my control. That was his cultural bias that basically put his life on the line. It's extremely rare for me. I think that may have been one of only 2 experiences that I've had in 30-something years of white patients that were negative." So again, this encounter from Edgar was pretty common from not necessarily the patient in this form, but this encounter of having that one experience that stands out that you remember because of its hostility or because of the pretty clear racial stereotyping related to it, that was fairly common for many Black doctors. And because the infrequency of those types of experiences were so pronounced, it made these doctors more aware of the structural aspects of medicine, like the lack of mentorship, the lack of networks, but it also left Black women doctors very aware of the gender dynamics of their work and the ways in which they experienced a lot of second guessing, doubts, marginalization, and so forth by virtue of being Black women in this field. And I include this quote from Aisha, a neonatologist, to make this point. And Aisha told me, because I see my coworkers that are males and the race doesn't matter. If you're male, they will call you a doctor. If you're female, they will call you a nurse. But it's regardless of your race. Like I see my white coworkers, even just because they're female, they still call them nurse. If they're male, they're a doctor. If they're female, they're a nurse. But the race doesn't really matter. It's the male versus female. That's more important than the race. And again, this was a pretty common response that I got from many Black women doctors in my study, who even when I asked them questions specifically about ways that race impacted their experiences, would give me responses that related to gender and say, well, as a Black woman doctor, people don't take me seriously, or my colleagues think that I'm just going to run off and have a baby, or I get called the nurse all the time, and I see that happening in ways that that relate to me and not my male coworkers. And I think, again, that this comes back from this interplay between race and gender, where with racial experiences being more structural, these everyday overt gendered experiences really stand out a lot more for Black women doctors. But ultimately, all of these experiences paint a picture for Black physicians where the type of cultural competence strategies that many facilities were using doesn't really relate to the types of realities and experiences that they are having. And it leaves them feeling a bit disconnected from and skeptical about these initiatives. So I want to turn to nurses next. If Black doctors were skeptical and felt that their institutions maybe were well-intentioned but were making mistakes in execution, nurses were very doubtful, very suspicious, and highly mistrustful of the facilities where they worked. And there are some reasons for this. For many Black nurses, they worked in places where the institutions where they were employed claimed to be diverse places or claimed to be places that cared about diversity. Black nurses largely felt that these claims were not reflected in their interactions, where they routinely described explicitly racist exchanges with their white colleagues. But unlike, or like the experiences that doctors had, Black nurses also observed structural processes that also served to disadvantage Black nurses. And as a consequence, they were highly mistrustful of diversity rhetoric due to the different racial realities of their work. And so I'll give some examples of what this looked like for nurses. So here's a quote that I have from Stephen, who is an orthopedic nurse. And Stephen told me at the time of our interview, when you look at the settings, the more people say that they're diverse, the more that they are not diverse. They're diverse on paper because you have to be. But if you're diverse on paper, you ought to be diverse in practice. One cannot go without the other. And when I say that to mean that when you're stating that you were a diverse program, your nursing staff should reflect that. I know one school where in the fall they admitted 50 students into the nursing program and none of them were African American. So that was not very representative of what their mission is. So Stephen is referring here to a specific example of this particular case, but he's also citing an observation that was pretty common, again, among Black nurses, which was this disconnect between what organizations say they value and what actually happens in practice. And for Black nurses, because of what they experienced in practice and because it often was so stark, it made their doubts about facilities really, really stand out. And here's an example that I give of Janet, who was a pediatric nurse. And Janet identified some of the structural barriers that were more along the lines of the ways that many Black doctors analyze some of the shortcomings in healthcare facilities. Janet said to me, the push is to have all nurses, the entry level be a Bachelor of Science in Nursing and not community college or diploma programs. So those nurses who do attend community college or diploma programs actually may find that they struggle a little bit more to obtain a job than those with a bachelor's degree. How many Black nurses go to community colleges because the tuition is less expensive? Or maybe it's a little bit easier to get into the program in terms of just the numbers of people that they accept or the feasibility of having a family and going to a community college. So what Janet is highlighting here again is this path to credentialing and the ways that for Black workers, Black people who are interested in nursing in particular, there may be multiple routes through which they get the training and the credentialing necessary for nursing. But in this effort to professionalize the field, this push to moving towards certain standards and certain expectations around credentialing may end up functionally becoming a structural dynamic that inadvertently perhaps leaves Black workers underrepresented in this path towards moving into this profession and filling a nursing shortage. Janet isn't identifying this as something that's intentionally or outright targeting Black workers, but she is pointing out a byproduct of this process in ways that it may have a structural impact on Black workers who are interested in this field. So Black workers like Janet were aware of these structural barriers. Black nurses like Mindy talked more about the interpersonal barriers that she faced. And the quote here from Mindy reads as such. Mindy told me, "I was just kind of noticing that there was just kind of this demeanor of how dare you be in intensive care because of your race. It never starts out as things that they say right out. Some nurses, some white nurses will kind of not say anything, but just kind of, they don't come right out and say it. It's the way that they look at you when you notice these subtle differences. But long story short, someone actually said to me, we were talking about after work, getting together, hanging out, and said, oh, you can come to my house, but you'd have to be carrying a pail and wearing a rag on your head to come to my home." So for Mindy, this overt implication that she was only welcome to socialize with coworkers if she was there in a cleaning capacity was par for the course. Mindy related this to me as one of many other examples of the types of interactions that she had with coworkers. So when I talk about Black doctors having that one-time experience, it's very dissimilar from what nurses like Mindy experienced. Their that one time was more of all the time. When doctors would say, there was that one time when this thing would happen, nurses would more so say, how much time do we have for this interview? Because just yesterday, this thing happened. And then 2 weeks ago, this other thing happened. And then a week before that, I had this awful interaction with my charge nurse and this thing happened. So these were pretty routine, commonplace experiences for Black nurses who also observed, again, that even as they were working in these environments where these types of interactions went unchecked and went unremarked upon by supervisors, sometimes these types of interactions came from supervisors, they still were employed in facilities that made it a point to say that they value diversity, while interactions like these went unacknowledged and unremarked. And those types of experiences give some understanding into why nurses were so skeptical around the diversity initiatives that they experienced, because they did not fit nor were they designed to address experiences like these, much less the more structural paradigms that nurses like Janet observed. So finally, I'm going to turn to Black technicians, who ironically were actually the most hopeful about diversity initiatives. And this is ironic for a couple of reasons. One, they weren't hopeful about these initiatives because they actually believed these initiatives would help them personally. And this is echoed by research that suggests that diversity rhetoric is actually rarely applied to lower status workers. They usually are not the focus of organizational efforts around diversity. It usually is higher status professional workers. So Black technicians were not expecting that these initiatives would do much to address their experiences, and existing diversity policies were usually not structured to address the types of hostile racial interactions that technicians had with both patients and with nurses. But technicians, despite having the most distance from these types of policies, were hopeful because they believed that these initiatives might help nurses and doctors treat patients of color more effectively. So here's a quote from Amber, who is a cardiac monitor technician. And Amber was expressing her favorable views about diversity programming in workplaces, and hers in particular, and was describing to me that she felt that it was a really good thing that her workplace had these types of initiatives in place. And so when I asked her what impact she thought it would have on her, she said, well, I don't actually think it will have any. And so when I asked her to say more about why that was, she said, I don't think that it'll impact the work that I do just because of my minimal patient contact that I have. But as far as everyone else, I do believe that it'll impact them. I'm thinking of the nurses and doctors that are being trained. It might make them go a little bit more of the extra mile to make sure everyone is comforted and kind of on the same level. Of course, they always go the extra mile, but now it's just adding another key role. So we see here that for Amber, the focus is not on how diversity could potentially impact her work or affect her professional experiences in the same way that it is true for nurses or for doctors. For her, it's more of a second party thing, that having diversity initiatives in place is good for patients, but it's also good for the people who are practitioners who are treating those patients to have a better understanding of what their needs and experiences and lives may be. And for the final quote that I'll share, this one comes from Callie, a patient care technician. And this gives some insights into, again, the types of interactions that technicians had that diversity initiatives were not equipped to address. Callie told me, okay, so not too long ago, I had this patient and I came to her room to get the baby. It was time to do the baby vitals and to do the PKU on the baby, and her family was in there. Her dad was in there. So when I came in, I did her vitals, and then I asked her, could I take the baby? And I told her I would be back in about 10 minutes. And her dad started going off because she was handing me the baby. And he was like, what are you doing? And she was like, oh, Dad, please don't start. And he was like, you don't know who she is. She's just coming in here, grabbing the baby, and she could be anyone. Look at her. I looked at him and I'm like, well, here's my badge. My badge had flipped around, so I turned it around. And he was like, that's the problem here. They'll let anyone work here. You people are lucky to be here. Again, this is pretty distinctive. It's pretty overt, but it's also very distinctive from what I described previously with regard to doctors, and not so much from nurses. But for patient care technicians or technicians in general like Callie, This was routine. This was a pretty commonplace aspect of the work experience, but it also was not the type of workplace experience that they expected diversity initiatives to try to address, because diversity initiatives usually are not geared to people like Callie who are doing this type of technical work and having these types of interactions with patients or with patients' families. So ironically, even though Callie is experiencing these interactions that look more like what I heard from nurses on an interpersonal level, there's a lot more optimism and a lot more hope among technicians, in the sense that even though diversity initiatives are not going to do much about these types of interactions, that perhaps they can have the potential to improve patient care for doctors and nurses and people who are interacting with patients on a more regular basis. So I want to conclude with a few points. I've argued here that when we think about work transformation in the new economy, this mainstreaming of diversity talk is one example of what this work transformation has looked like. And even now, as we're in this era where there's been this pressure to cut back on diversity and diversity initiatives, it still represents this idea that talking about and some attention to diversity have become pretty normative and have become pretty mainstream in many of our industries, organizations, and workplaces. But what I've tried to show here is that what diversity actually means depends really heavily on occupational status. What diversity is for doctors is not synonymous with what diversity is for nurses. What diversity is for nurses doesn't mean the same thing as what diversity means for technicians. And overall, the way that a lot of diversity programming had been implemented does not address how key aspects of work maintain racial inequalities. And this is the subject of my most recent book, the one that Max mentioned in the introduction. When I talk in my more recent book, Gray Areas, I focus more on examples from hiring, from organizational culture, from advancement. And some of that comes through in the examples that I've cited here. When we talk about workers dealing with an organizational culture where it may be normal to hang out after work, but part of the norm of that culture is that there are very racially skewed demographics around who hangs out together in a workplace. That is a core component of organizational culture. When it comes to advancement and the need for mentors and people who can guide and support your career, that is a fundamental aspect of how people experience occupational mobility in workplaces today. But those aspects of how we work are often fundamentally shaped in ways that reflect racial inequalities and allow racial dynamics and racial inequalities to perpetuate. What I try to show here is that those aspects of work are also driven by structural and interpersonal factors, and that they vary by occupation, and they also have gender dimensions. And this is why when we look at Black doctors, nurses, and technicians in separate groups, we see differences between what Black women doctors say around the experience of organizational culture, feeling very gender driven in ways that highlight their marginality as Black women in those professions. This has a lot to do with why we see nurses navigating an organizational culture where racist remarks can be unremarkable. Same for technicians. This aspect of work transformation overall has been one where organizations have adopted this language and these statements around diversity in ways that have not necessarily translated to a core understanding of what Black workers' experiences actually mean in practice, nor the ways that they vary along occupational or gendered lines, and as a result has largely left Black professionals feeling pretty disillusioned and disengaged. Now, because I like to try to leave presentations on a high note and not have people regretting they invited me because I bummed them out, I do want to say that while I've presented a pretty bleak picture here, I do think that even in the times that we are in, where we're seeing this incredible backlash towards diversity and inclusion, there's still some room and some pathways forward for organizations to take to keep those goals in mind if they are so motivated to do so. And ironically, I think in the healthcare industry, this is one of the fields and one of the areas where I think there's probably perhaps more promise than many other industries. And the reason that I say this is that and all this work that I've done on trying to understand healthcare from a social scientist perspective and trying to understand the norms and the industry and the culture behind that, it does seem that one of the kind of truisms and understanding in healthcare now has been this idea that we are moving towards a more racially diverse society. That is simply a fact. And that a practitioner population that does not reflect that diversity is not necessarily going to be best served to achieve these goals around care, around providing care for people and around people's health. I think that there's room for healthcare in particular as an industry to build on that and to build on those insights in ways that make sure that practitioners are aware not only of the types of inequalities in the life chances and the life factors that are shaping patients, but to understand as well what that means for practitioners and what that means for the Black doctors, nurses, and technicians who show up every day to try to do this work, and to do this work in ways that often can be isolating and feel exclusive, and feel some of the things that Max talked about in the introduction of feeling as if you're the one person in this space. The other thing that I'll say that, again, gives rise to very guarded and cautious optimism is that when we look at the data that does talk about things that organizations and companies can do, there are still mechanisms that companies can take that still remain legal, that still have not been outlawed by the Supreme Court or by executive orders, that can still go to facilitate more diversity. Companies can still engage in broad mentoring programs, for example, that include everybody in the mentoring experience. Companies can still cast a wide net when it comes to recruitment and make sure that they are pulling not just from a few Ivy League universities or Ivy adjacent universities, but that they are reaching different places for entry level or open positions. Companies can still engage in processes where they are aware of making sure that people have sponsors that are critical for advancement and upward mobility. So there are some things that companies can still do, even as we are in this place of enormous backlash. And I think that in healthcare in particular, because there's this awareness of how practitioners are treating a diversifying population, it's actually a field that I think could potentially be ripe to highlight and show the way to do this type of work going forward, even in a climate that's not necessarily super receptive to it right now. So I want to stop there. Thank you for your time and for your attention. I'm happy to take any questions, comments, or thoughts that anyone has. Do I need to pass this thing around?
If anybody has any questions, let me know. I'll pass you the cube.
Thank you so much for your talk, Dr. Harvey Wingfield. I wanted to ask if in your research you'd come across what I've seen a lot of like colleagues of mine doing, a lot of folks who did come in this wave of like diversity in medicine, being young doctors and either deciding not to go pursue residency or to leave the profession. Because I've seen that a lot, and a lot of even prominent doctors, I forget her name, but she's a prominent doctor in New York who just wrote a book. Yes. She also left medicine. So wondering if you've seen that pattern as well, or have any kind of reflections on how that fits with this kind of like promise of diversity, and then this kind of, at least for me and like folks that I talk to also in the process of becoming a physician, like the realities, confronting the realities of what medicine actually is.
Yeah, that's such a great question. So anecdotally, I would say yes. I know of anecdotes where that's happened. I have not looked at data yet to see if what I've seen anecdotally is playing out across the board. I'd say it would not surprise me though, right? It would. My hypothesis would be that we are likely to probably see depreciation in diversity, not even just in healthcare, but in a number of fields as a consequence of the actions that are being taken right now, which are intentionally driven to try to drive down and dampen diversity efforts. I mean, there are many unfortunate things about that, not least of which I think is the cost that has to the profession and to the health of our population. But I think that that's probably widespread. Again, my hypothesis would be that's probably widespread in healthcare and other fields that are being affected by kind of the full frontal assaults on diversity. Yeah.
Thank you so much for this wonderful talk. I just want to add, in addition to that, I think in general, Black physicians are more likely to leave academia because of all of the experiences that you described, like lack of mentorship, lack of sort of like advancement opportunities, and in part also because or I guess we are less likely to be promoted. So there's this big issue where it's like this bad cycle, right? You're like less likely to remain in academia, and therefore less likely to be a face that is present to like help the next generation, which is, I think it's sad. One thing that I'm curious about, Dr. Harvey Wingfield, from your research is how much, I guess, like cross talk your research subjects brought up in terms of interactions with people at other levels. Like, so like nurses talked about interactions among themselves and their nursing supervisors. I'm asking this because so I like to think I was pretty observant as a med student, and there are a couple of things that I noticed. One, for instance, when like janitors or like patient transport folks would like be walking down the hall, I think in my like 2 years on the wards as a student, I noticed maybe one or two attending physicians actually acknowledge the janitor and say, "Hey, how are you?" Um, and the flip side of that is I notice a lot of somewhat hostile interactions where like someone who's coming down the hall with like their big trash can to sweep or whatever, we doctors take up the entire, we're like a big thrombus in the hallway. It's like these huge teams that are blocking people's way who are like we essentially block people from doing their work, and they would like say excuse me, but in a way that it's clear that we annoy them. And I used to wonder how much of that has to do with the fact that on average, in general, we don't acknowledge them as like people who are here sharing the space with us and like as part of our team. The other thing that I noticed when I was a student was that a lot of the more overt racist comments, as has been mentioned here, came from like nursing and like let's say OR tech staff, and I used to wonder how much of that difference had to do with like differences in class backgrounds, like within each profession, right? Like to become a physician, I think the majority of people who go to medical school come from the top 1/5 of income or like household income in this country, and in sort of like liberal, well-off, polite society, it is not appropriate to make like off-color jokes or whatever. Whereas like people who go to nursing school or to be OR techs don't come from nearly as well-off backgrounds, and there are different. I don't know if standards is the term, but there's just different norms in terms of like what is like a socially acceptable comment to make. And I remember many a times in the operating room, the most racist things I ever heard were often said in the OR by nursing techs or by nurses. And I used to wonder, like, do people I work with who are from well-off backgrounds actually share these views but don't like say it out loud because it's not acceptable in polite societies? And so then I feel the brunt of that kind of like interpersonal bit more so because I'm like the powerless med student in the space, and I can't like retort, right? Because as an attending now, no one says anything inappropriate around me. But I'm curious what your thoughts are on this sort of like class, the impact of class in shaping the experience, like the sort of like class that precedes this, where people are in the profession and shaping those experiences of racism.
Yeah, that's another really great question. So I tried to grapple with this less so from the question of nurses, but more so from the perspective to try to understand what's happening with physicians, right? I guess around part of what you're raising in terms of what it means to be kind of at that top of the organizational hierarchy, but yet to be in a place where you're like you said, people are they just being genteel? Are they not saying what they actually think because it's considered inappropriate? Is there some aspect of occupational culture that precludes them from doing it or something else? And so what I think, and I talk about this in the book, I think there are a couple of factors at play that relate to some aspects of the social dimensions of how healthcare is organized, right? So what I mean by that specifically are that when I talk to respondents, I think what protected them in many cases from what protected doctors in ways that did not protect nurses are the ways that healthcare is organized to give more autonomy and independence and isolation is not the right word, but yeah, autonomy and independence to doctors in certain ways that I think are not present for nurses, right? So by way of example, the Black woman pediatrician that I shadowed, when I went about kind of following her routine for the day, she would come in, she would sit at her little desk by herself, and she would do her charts to prepare to go in and see the next patient. She would go in, talk to the patient, she would come out, do her charts again. She had some team meetings sometimes, but a lot of her work was very autonomous. And she also pointed out to me that she had situations where patients would say to her point blank, white patients would say, I brought my kids to you because, I want them to see that people of color can do anything in this country. And I want to make a point about, your doctor is a Black woman and look how far we've come and look at the progress that we've made, right? Now, does that necessarily mean that these doctors are in a place where they're around people who are not having these types of racial views? I think not necessarily, right? I think when we think about how healthcare is organized from the patient standpoint, if you have private insurance and you want to go see your doctor, how do you find a doctor? You go look online, you see who's in your network, and you can actually use kind of market forces to self-select the person that you want to be your doctor. So if I'm this virulent racist and I don't want any Black person coming anywhere near me or my kids, it's pretty easy to make sure that that doesn't happen, right? And I think that for many Black doctors, the autonomy of the job, plus the social organization of care and the market-driven dynamic of it, put them in a place where they weren't quite self-selected out, but people who might have otherwise created harder environments for them were self-selecting themselves out. So they were left with patient populations that were more supportive. The other thing that makes me think that is that when I look at the exception to that among my data set, it was largely among emergency medicine doctors. And they were the ones whose experiences looked a lot more like the nurses. They had some stories that probably all of you in here can imagine or can expect, right? But their stories were a lot more like the nurses. And I think a lot of that has to do with the fact that if you're in emergency care, one, people are seeing you in an emergency, they're not in their best, but you also have a lot less control over who is going to be your emergency doctor. You get whoever is on staff there. And I think that's why for those healthcare workers, they experienced dynamics that were much more overt and explicit, and again, much more like what nurses experienced. So I wouldn't necessarily say when it comes to doctors that I think it's completely around the pre-existing class background that people bring into it, or that people are necessarily kind of occupying this more genteel space where you don't say those types of things. I think there are fewer opportunities for Black doctors to hear those types of things because of the way that their work is set up and because of the way that patient dynamics are set up. But again, I think if you, let's say I'm, again, this super racist person, I don't want a Black doctor near my kid, I can control not taking my kid to the Black pediatrician, but if a Black nurse comes in the room, I can't control that, right? And I can just be rude and racist and awful to nurses. And I think that those dynamics are part of why I think those gaps were present, or those differences were present between what nurses were sharing and what doctors were saying.
That makes so much sense. As you're saying this, I'm thinking about residency and the rotations where I felt like I experienced more like aggression or disrespect from nurses, and it was always more in the ICU where even the physical space within which we worked created more opportunity for nurses to come into my workroom and say inappropriate things, or like, whereas like on a regular, like on a floor rotation, I would see the nurses in the morning and then like maybe not again until there's a need that arose. Whereas like in the ICU, we're sitting in an open space and you have access to me all day. So yeah, that makes a lot of sense. Like just the way work is structured. Yeah.
Hi, thank you so much, Dr. Harvey Wingfield. This has been really, really interesting. And I was curious because you mentioned the saliency of gender for Black women physicians. And I was curious in specific fields like OB-GYN, where the physician population is disproportionately female. I mean, considering the patient base, I don't think it's disproportionate, but so when you have physicians that are Black women physicians in a field where it is predominantly other women, do you see more commentary on racial differences? And then my second question, I kind of forgot. I'll stick with that one for now.
Okay, if it comes back to you, I'm happy to answer it. So in terms of the more gendered fields in that way, like OBGYN, that presents an interesting case, right? Because you do see more women in that field where I found that not so much racial commentary emerged, but racial differences or distances emerged, had to do with healthcare providers' interactions with and treatment of patients from certain patient backgrounds, right? So one of the doctors that I shadowed, I mentioned, her name in the book is Ella, and she was an OB-GYN in a research hospital. And she was part of what made me really start thinking about what I refer to in the book as this idea of equity work, this additional labor that Black healthcare providers do in the absence of effective diversity mechanisms in organizations. And I thought about that with Ella because I shadowed her for a full day. We went around, rounding and seeing patients and so forth. And then at the end of what I felt was an extremely long day, she went back to her office and started calling patients who were in a pregnancy group that she had organized for low-income people in the community to get some prenatal care. So we finished this workday, again, already a long work day, and she's going and calling people and saying, you know, just remember, we've got this group meeting tomorrow and we'll be at such and such a place and we'll be at such and such a time, just calling to make sure you're going. And I remember asking her, you know, what is this? And why are you doing this? And why are you the person who has to make these calls? This was a thing that she set up entirely on her own. And she set it up in part because she felt so frustrated and upset by the way that she saw particularly low income Black women being treated in the facility, in the ways that they were dismissed, the ways they were marginalized, the ways they were not taken seriously, the ways that colleagues interacted with them based on pre-existing stereotypes of who they were and why they made the choices that they did. So this became a whole other thing that she did in an environment where you might think from the outside looking in that wouldn't be necessary, right? You might think, oh, this is OBGYN. People understand that, you know, different factors are going to have an impact on health disparities and why certain groups may make certain choices. She did not find that to be true. And so she took it upon herself to try to rectify and address that. So we're gonna.
No, yeah, that actually thank you so much. Sorry. That actually reminded me of my second
Okay.
question. So you talked about self-selection into certain roles because of, you know, dealing with various racism, structural, systemic issues, interpersonal issues, and even, you know, it made me think about your difference between private and public.
Mhm.
And I was curious if you had come across a higher number of Black medical providers in community centers and health clinics that are more public and open hospitals that are more public
Mhm.
because they're more likely to serve a patient base that is going to be more racially similar to them. And I was curious if you saw differences in the racial breakdown of private versus public medical care as well on the provider side.
Yes, that is actually chapter 5 of the book. The whole
Oh,
chapter.
good. I can't wait to read it.
Yes, that whole chapter focuses on Black workers in the public sector. So at the risk of giving away too much, I'll just say that, again, being in this environment that's being consistently underfunded had an enormous impact on the Black workers who were in that space, because a lot of them did go into it intentionally. It was very much by design. It was very much so because they saw this is an area of the greatest need, and they had a certain expectation of familiarity with the patients that they would be treating, but they also dealt with a lot in terms of the underfunding and the stress that placed on them and the needs that placed on them trying to care for these populations, as they saw that the leadership from their viewpoint did not seem that focused on trying to fight for resources and offer supports to these places that they saw were going to more well-off places right across the city. Mhm.
All right. So Dr. Harvey Wingfield. So first off, I want to say welcome to UCLA.
Thank you.
Thank you so much for your talk. It's such a inspiring and thought-provoking share of your work. My name is Jay Lee. So I'm one of the co-sponsors. I co-lead the Health Equity and Translational Social Science research team here in the David Geffen School of Medicine. A lot of the work that I do, I'm an epidemiologist by training, but a lot of the work that I do is around health equity and how do you do meaningful community partnership. So I think thinking about your talk on so I don't know if I have a question, but I wanted your comment. So I think in terms of, you know, diversity initiatives and mentorship. So a lot of diversity initiatives, I feel like it's always sort of checkbox or reactive. So we think about, you know, many years ago when George Floyd incident happened, I think a lot of the academic institutions, you know, there was a huge resurgence of diversity, anti-racism activities, but oftentimes I think those initiatives were not representative, or they weren't including people that would benefit or that would really co-design such initiatives. And it was almost like performative and almost like a checkbox. And then after a while, the initiatives just kind of disappeared. So in terms of the current administration and the opportunity, I wanted your comment about how do we, instead of being reactive, how do we, you know, kind of project and be proactive about leveraging the current situation to really elevate inclusiveness and diversity. So that's one question or comment. And then the other one about, you know, mentorship. So I kind of think about the, you know, the amazing mentors in our David Geffen School of Medicine who are Black, and we don't have that many, right? So how do you change that cycle? And then also in terms of many Black physician scientists, I think the value of having peer mentorship is really important. But I think the culture has to do with a lot of whether the peer mentors are collaborative or are they competitive. And sometimes it can go the other way where, they don't want to, support each other because they themselves have a lot of like stress and pressure on them. So how do you change the culture also instead of like being reactive, being proactive and kind of looking forward?
Yeah, so those are great questions that actually relate to each other in some ways. And the reason I say that is that when we deal with this question of mentoring, data are pretty conclusive in showing that that's so critical and so essential for advancement, right? Just across the board. But what the data also show are that for Black workers, especially when mentoring programs are left to kind of develop organically and people just are paired with, but left to pair on their own with whomever, often Black workers get left out of those types of pairings. So what researchers in this area recommend are more explicit, overt mentoring programs that are actually organized by someone where everybody who wants a mentor has access to one. And what the data show are that when that happens, Black workers are more likely to sign up. They're more likely, obviously, be matched with someone because it's a program for everyone, but they also generate social connections and support and networks that they otherwise would not have, right? And the thinking behind that is that when companies have mentoring programs where HR decides to select people who seem like high performers, right, then those are people who are probably on a pretty solid track towards doing well in the organization anyway. But when companies have it in place to where everybody has a mentor, Black workers who might otherwise get overlooked have access to someone who's higher ranked in the organization, who they might otherwise not know about at all, who can get a better insight and window into the types of things that they are dealing with and that they are experiencing. So I really stress those types of programs a lot when I talk to people about the implications of what we can do when we think about diversity, equity, and inclusion even now, because it's an example of, again, the type of programming that is still legal, right? It's still perfectly legal to have mentoring programs. It's legal for everyone, at least now, to be a part of a mentoring program. It doesn't run you afoul of anyone who might feel uncomfortable around DEI as an idea, but it also yields results, right? And it yields results in ways that still fall into accepted categories and processes, right? The other thing that comes out of these types of mentoring programs, to your point about peer mentoring, which is very valuable, but like you said, can also run the risk of not offering the same type of support structure, is that when everybody has access to a mentor, one of the things that comes out of the research is that that actually changes not just the mentee's trajectory, but the mentor's experience, right? Because mentors are often, again, paired with people they otherwise would not know and get a really interesting and unique window into what their mentees' struggles might be, what their experiences might be, where there might be things kind of lacking in the organization. And I think those types of connections and that type of knowledge may not necessarily make up for a culture of more competitiveness among peer mentors, but at least it puts everybody in a position where they've got access to some resources that can be really key and critical. And a lot of the research that comes out now about ways that we can be more proactive about diversity, especially right now when it's not the buzzword that it was 5 years ago, is that a critical part of a lot of interventions is just taking away what we would call the hidden curriculum, the taken for granted parts of workplaces and the informal norms in workplaces that are unstructured, but still often tend to disproportionately favor white workers who have cultural capital or knowledge of how organizations work or connections or what have you, right? When those things are available to everyone, when everyone has a mentor, when everyone has a network of people that they can draw on, when everybody has access to the same resources, you actually see more improvement when it comes to diversity because people aren't doing this dual task of trying to do their job and then figure out the informal norms of the organization. They're not trying to also learn the organizational culture. They're not trying to know the things that are unspoken, but that people who are already highly placed already know because they have connections and networks. When those things become available to everybody, we're a lot more likely to see more flourishing. So I think when we talk about how to kind of meet this moment that we're in, it's really incumbent for organizations to draw from the data and the research and to put into place the types of strategies that have been shown to be beneficial to a wide variety of workers, especially since, again, a lot of those strategies are things that we can still be doing. I think it's critical to do them now before the culture changes even more and while there's still room for those types of initiatives to be implemented.
Thank you so much for this talk and this Q&A. I'm gathering a lot. And one thing that I keep thinking about is language and terminology. And I know that you talked about how you were framing diversity ideologies. And I think you were saying you also asked your participants about diversity. But I was curious about like that I know words mean things, but in this context, people are trying to be strategic about what words we use. Diversity to me is pretty neutral, right? It's like variation as compared to equity. But even diversity is under attack. So I'm just curious, like what value you see in talking about diversity, or what value the participants really see, and if they were also pushing back against any of that language, or like what if there was a way to think through the concept or the ideologies like beyond diversity, what could that look like?
Yeah, that's interesting as well. So for these respondents, the data were all collected at a time when we were not in the place we are now, where diversity was quite the flashpoint that it is, right? It was pretty unremarkable and normal for many companies to, have a page about diversity and say that it was something that they supported and that they were in favor of, and just, straightforward about. But I think, obviously, if I ask these respondents today, we're in a different time and place in a different era. And I feel like part of your question, if I understand you right, is just thinking about what that wording means and how people hear it, and what it means that they are responding to when they're being asked questions around diversity, right? I think today, if I asked a lot of these questions, I'd get not necessarily different answers in terms of respondents' racial workplace experiences, but I think I would definitely get different answers in terms of what they see their organizations doing around diversity, how it's framed, and what they think the organizational culture is around even using that wording and that language, and what objectives they're trying to put into place. I think they'd, in many cases, and I know for sure, thinking of some of the people that I interviewed and where they are, that they would be in places where that walk back and that retreat from the language around diversity hasn't, again, changed their racial workplace experiences at all, but probably has reinforced some of the skepticism, doubts, or outright hostility they had about their organization's seriousness about or commitment to these types of issues.
Yes. I'm like, Todd? You got it?
Okay. Awesome. I just wanted, just a comment, I just really wanted to thank you for this conversation, especially as someone currently applying for medical school. I thought it was very helpful to hear about. It made me even reflect on some of the experiences that I've gathered in getting clinical hours, and I did it mostly in the ER, and I saw so much racial comments just to people that looked like me, and how people that looked like me were treated in that department. And so I just really wanted to thank you on your work. I found it very valuable.
Thank you.
You got taco?
Well, if we don't. Oh, we do. Okay. Great.
Oh, good. We calm that down. I got you.
Thank you. This was amazing. And it's maybe more so a comment, question, just discussion in general. There's so many intersectionalities to systemic racism and how it's rooted throughout society and the health system. I went up to the Capitol earlier this year. I don't do a lot of that type of work, but I'm really leaning in towards like legislation, passing laws and things of the sort that really are promoting reducing these health disparities. But one thing I wanted to mention, or one law I wanted to call out actually, was SB 679, which is actually attempting to be passed. And what SB 679 is actually, what we know is that Black and Latinx students, or medical students, residents, are disproportionately dismissed from their institutions. They're more likely to receive or lose their privileges, and just more likely to be kicked out of these programs, of course, which in terms continues to reduce the number of these physicians that are so needed in our communities. But I think when I'm thinking of these things, and I'm thinking of how even in California, we need this law. And what the law is basically going to do is require these boards to provide information like who is more likely to get kicked out? Because right now it's more so like word of mouth. We know this is occurring, but in terms of actual lists, they aren't able to identify the folks. They can't say the race or gender of these individuals. And so the law is really pushing on to be able to name these things so that we can call out, hey, this is actually happening. This discrimination is occurring in these spaces. All that to say, California, which I think I'm so privileged to be from California, it's a way, it's a lot more accepting place, a lot more movement, or so what we think. But I'm wondering, like, how do we keep, especially if in places like California where we're way more advanced, I think, in terms of calling these things out, like, how do we keep the needle or keep this work going when even California we're having these problems? How do we do it all around the country, especially if right now we even in this state, it's, we have to pass this law to even call out these things. So I guess, like, how do we keep it going? How do we keep these practices and doing things of the sort when
Yeah,
it's hard?
that's a really interesting question
Yeah.
too. I mean, I don't know that I have specific step answers. I will say, Whitney mentioned that I'm finishing a term, or have finished a term as president of the American Sociological Association.
Mhm.
So one of the things that I wrote about for my presidential address was thinking about what comes after DEI, right?
Yeah.
What is going to happen, because it's yeah right. So what's going to come after this phase? And one of the points that I tried to argue was that I think moving past DEI doesn't have to be a catastrophe if what comes after it are policies that seek to make work better writ large for everyone, while also taking into consideration a few facts. The fact that there are racial disparities at work, and that certain groups are specifically affected by that those issues are intersectional, that they are complicated, they're complex, but that they have to get fixed if we're going to make work not be what I described in the second slide, right? And so part of the point that I make there is that sounds easier said than done. But again, I think there are some glimmers for points to highlight and to emphasize, right? And those glimmers come from the fact that there are societal signs, broadly speaking, that people recognize that work is bad and it's dangerous and it's harmful and it's not rewarding in many cases, and that it could and should be better, right? And there's also work by social movement scholars that suggests that there are ways to think about how to kind of get people's mindsets into places where they are thinking about kind of big group dynamics and big outcomes, right? Jennifer Richardson is a psychologist at Yale, and part of what she finds is that when people have a more structural understanding of racism rather than an interpersonal one, they're more likely to support policies to create more racial equity, right? Other sociologists have found that when people identify kind of broad goals for a movement, then they're more likely to want to see those broad goals put into place when they align with the movement's framing. So I feel like we're at this place now where, again, work is really very harmful for many people, right? And there's a lot of awareness around that. And there's support, even in red states like Missouri, where I live, which is probably as far opposite of California as you can get, right? Missouri passed the minimum wage increase this year, which is not, and a sick leave policy, which is not nothing, and which I wasn't actually expecting as a resident of Missouri. But I feel like that speaks to people being aware that work is really unpleasant and dangerous for many people, and the awareness being that it doesn't have to be, right? It's not like it just got this way by accident. It got this way because of a series of policy decisions that got made, which means that different policy decisions could be made to make work better. And I think the key is to think about how to harness that energy in a way that, for a change, actually includes underrepresented workers, specifically Black workers, Asian American workers, Latinx workers, Native American workers, right? All those groups need to be brought into this effort to make work better. And I think that's not what happened in the past, but I think that the discontent could potentially be a pathway towards doing that if we do it in a way that makes these racial issues a core part of how we improve work and not just something that's tangential. So again, it's not like specific, here's what we do first, and then here's this next thing, right? But I guess it's weird to say that I'm slightly encouraged by how, how uncertain and shaky work is. But I also think that eventually, people do push back and they do stand up and they do say, enough is enough. And we're at a point where work is not getting better, at least under current policy decisions that are being made. And I think it has to be only a matter of time before people are just like, we're done with this and things have got to change.
Yeah.
So.
I agree.
Now I think we're mostly done. Is there any more questions? Okay, well, thank you again
Thank you.
for this inspiring talk. There is a little bit of